all these things, subrogation, coordination of benefits, denying claims, some of the insurance companies using pre-existing as you've already had that procedure, so we're not gonna pay for it again. All of it just is the fact that it's ridiculously expensive.
Yeah.
And it wasn't that long ago, I think, the average per employee per year cost, commercial plan, was right around $5,000. And now today, latest stats I saw from either it was Mercer or Milliman, it's close to $18,000 PEPY.
And it was 15 in 2020. Welcome to Claim Talk. I'm your host, Danielle Young, and we have some fabulous guests here today to discuss the concept of claims denials, what causes them, how they happen, how a plan can maybe circumvent those. It's a hot topic right now. It's been something that's obviously been discussed widely around the healthcare system and perhaps its imperfections. So I'm going to have our guests introduce themselves, give us a little bit of background, tell us your professional background, and what you do today would be fantastic. You want to kick us off, Carrie?
Sure. I'm Carrie Kennedy, and I have been with ClaimTalk for a year, and I've been in the healthcare space for 25 years on the private side, health system side, and prior to that, I worked on the healthcare IT side. So I'm super excited to be here, and denials and claims management, as being the claims manager now, has definitely came back into my world.
Alex Arnet, Chief Commercial Officer and co-founder of Lucent Health, 35 plus years in the industry, started out as an underwriter for Prudential, got lured away by United, did well there. I was employee number 400, by the way.
Oh.
And then when I left, it was 80,000 or 100,000 people, but spun off a company and sold it back to United. And then spring forward to now, everything I do now is just around self-funded healthcare plans and managing plans in the right way. Excited to be here.
Great.
Yeah, good morning, guys. Colton Casonand, Director of Operations over at iOrthopedics here locally in Des Moines. A little over 400 employees, subspecialty orthopedic group, privately owned, been there 11 years. Started at the ground level as a rad tech, and have kind of worked my way throughout the company, learning the rev cycle, coding, billing, a little bit of work comp, and so been a fun ride.
Great.
Happy to be here, guys.
Yeah, thanks for being here. Thanks for your travel and for your time. Something that we talk about on our podcast that's really important to us is making sure that we're educating the broker community, the consultant community, but also the employer community. So at times I might have to ask you to define things for our listenership that might not be fully aware of all of the acronyms that we like to use on a regular basis. So let me ask my first ignorant question. Legitimately, I don't know. What is rad tech?
Radiologic technologist.
Okay.
X-ray tech.
X-ray tech. Okay.
X-ray tech.
Got
Yeah.
it.
So
Got it.
started on the healthcare path and then kind of flipped. And now I've, learned the insurance side of the world is
The fun stuff.
The fun stuff. Yeah.
The operation.
The never-ending black hole.
Getting deeper.
Yeah.
Yep.
Yeah, so I'm going to kick it to you, Alex. The first real topic we wanted to talk about around claims denials was what we call technical errors, which could happen namely on the provider side, can also happen on the insurer side, correct? Do you want to elaborate a little bit on what we mean by technical errors when we're talking about claim denials?
From our perspective as a health plan administrator, what we will see is in most cases, it's on generally very large claim bills, oftentimes coming from the hospital. And so what you'll basically see, you'll see hundreds of lines of claims and different codes and service codes. And what the claim systems basically do is that they're basically going to look at all of that information and they're going to track every one of those service codes back to the original diagnosis and to the treatment plan. And oftentimes what you will see in that kind of technical review of the claim is that many of the items in there don't make sense to either the procedure that was performed and the diagnosis. So in some cases, remember, most of my clients are self-funded. So ERISA, that is a federal, regulation that was passed, 50 some odd years ago.
1974.
Thank you. See, 51 years ago. It's close.
Close.
So, but the bottom line is the plan sponsor has the fiduciary responsibility to utilize those plan funds in an appropriate way, an accurate way. And you're starting to see a lot of lawsuits around that too, especially around pharmacy. But as it relates to this, their job is to process and pay those claims on behalf of the member in an appropriate and fiduciary manner. So our job is to make sure that we're paying properly and we're not overpaying and we're not paying for stuff that either didn't get done or shouldn't have been done. That's what you'd see oftentimes, the technical denial.
We get a lot of claims in, about 25%, that have errors, things that are simple. The date of birth is mismatched with the subscriber versus the member. Middle name is flipped for the first name. So those things make it very difficult to even find the member to process the claim. So we get claims all the time that have information that's incorrect. And sometimes it comes from the provider. Sometimes it comes from the health plan having the provider or the member in as a different way. So we have providers that don't match because maybe it's the flipped name. It could be the member that doesn't match because, oh, by the way, I go by my middle name, but I told you that, but my plan is really under my real first name, or it's a junior, senior, or we get the date of births mixed up with the subscriber versus the patient. And then we can't match those claims, and then we have to deny them because we have to send them back and say, who is this, if we can't find them.
So it's essentially like an eligibility mishap,
Yep.
more or less, as a
Yep.
technical error.
But when a provider sees eligibility, they think that the member's not eligible when it's really more of a data entry error that someone at the front desk made, or someone, that was entering things into the system. And we see a lot of those, 25% on our side.
Wow, it's a big number. We try to level up at iOrtho with having steps in place to ensure all of that's accurate, right? Some pre-check eligibility.
Yes.
Having them verify on the tablets and when they check in, and then having really in tune staff that are making sure that's correct. Because that's just if we don't get it right the first time, it's causing back end time
Comes
and
back to
work.
you, right?
Exactly.
Yeah, and you have to pay people to
Yeah,
resolve
yeah,
that.
yes,
and so
correct,
it becomes
yeah.
expensive at the provider level. It becomes expensive at the plan level.
Yep. First of the year is always tough because, you have new cards. A lot of people have new cards. They forget to update them.
Yep.
Then your claim comes through, denied, or maybe even switched TPA. So the old TPA doesn't know, their system hasn't seen it yet, and they're flipped. And all these are just denials, especially in the first part of the year. Always lots of denials related to insurance has changed for the member, the TPA, those types of things.
For sure. Our first month of the year, historically, we're always very cognizant of calling our surgical patients that we have scheduled at our surgery center to make sure that, hey, you've not changed benefits, just to make sure that, hey, we might have got authorization in December, but when we have a January surgery, we know things could change possibly.
Yeah,
So,
you want to ensure the continuity of the care episode. in that
exactly.
type
Not
of
moving a
situation.
case, and majority of orthopedics is elective-based procedures, but we do have some cases that need taken care of emergently, and we want to make sure we're not delaying patient care as we're trying to sort out a change in a health plan. So,
Meanwhile, someone's got an ACL tear or something, and they
Yeah.
can't walk, and it's
Exactly.
like, we got to do this right now. We don't have
Yeah.
time to manage this.
Well, think about even that simple thing, getting out a new ID card, which can create all these technical problems. The industry still relies on sending out a plastic card.
Yep.
And depending upon when that employer made the decision to make a change in their plan provider, you probably won't have if it's in December and you're Jan 1, we all know that there's millions of cards going out. There's going to be a delay. So the question really is, why isn't the industry using more of your mobile app? And
Yeah.
you can automatically put your ID card. I don't even use my plastic card. I use my iPhone for that.
Right.
Everything's right there.
Yep.
And I can update as a plan administrator. I can update the ID card on your mobile app much more quicker than I can update these cards, these archaic cards, and sending it to the member. Now, does every member have an iPhone that you would need? But they say about 85% of Americans, generally working population, have a mobile app.
smartphone.
A
Yeah.
smartphone.
Yeah.
So just that little thing. And how does the industry, why do we continue to rely on old technology to make something simpler? We've got to do a better job. And part of it's got to be, how do we work better with the employers, but how do we make technology our friend?
I think it'd be great if in 5 years we could all prove eligibility on our smartphone. I don't think anyone has the incentive to make us all row in the same direction because the claim denials and the errors that come up and arise out of the chaos and the disruption of it makes people money. It makes insurance companies money, namely,
That's a fair point.
Yeah, we
Agreed.
can segue right into subrogation on
Yes,
that one,
please.
because I
Let's
think
go.
that's a
Let's
great,
get into subrogation.
a great one. So we have members who will go in for, say, they have shoulder pain. Okay, what do they usually get after the second visit? Probably an X-ray. As soon as they have an X-ray on there, most BUCAs will automatically deny the claim for it might be related to an accident or injury. And then you get a letter in the mail, and those members get that letter in the mail and they ignore it because it's not related to it, right?
Or they don't understand what it is,
Yep.
and so they throw it away or
Yep,
whatever.
they throw it away. Then the insurance plan keeps sending them messages. Well, then eventually they deny it to the provider. Provider then has to say, oh, well, member hasn't done anything. I'm going to bill them because it's denied. So now we've prolonged this months. Now we still don't get it. And it's like, it was just this piece of paper. But I will say from personal experience, they also don't make it easy for those.
I was going to say some
subrogation.
administrators will require you to
Mail it in still today. A certain one will make you fill it out on paper. You cannot call, you cannot fax, you cannot email. You must mail it to them in the mail. My suggestion to anyone who does get a subrogation letter about medical accident related, fill it out. Just get it, fill it out. It prolongs it. And I will tell you that a person I used to work with told me, oh yeah, 20% of our claims that go out on subrogation, they never get paid. Think about that for a second, 20%. And then it goes to the member, and then the member says, well, I'm not paying it, and it goes to collections, and we all know what happens when it goes to collections. So subrogation is one of those things, and it's a nasty little thing that it's automatic. Diagnosis code is certain procedure, usually extremities, x-rays, those types of things, all just trigger it right there. And it's like, how do you educate people? Just fill it out. Just send it back. It'll save so much time.
Think about how many members actually pay the bill,
Yep.
and they shouldn't have paid the bill. That happens across the board.
Oh, yeah.
You
Right?
bet.
Because they're afraid somehow they're going to get their credit ratings going to get attacked.
Yes.
And then if you look at the whole subrogation process, right? Like from our perspective, we're protecting the self-funded
The plan
employer,
assets.
The plan,
Yeah.
the plan assets. So you go through this whole, let's say it's a car accident. So it is legit subrogation. And let's say it's $1 million claim. And it should have been subrogated back to whomever, whether it's the auto insurance or
the other driver's auto.
other driver's auto. And then in some cases, the employer's like, no, just pay and pursue. So you go pay it. Then you find out later that most of that money should have been spread, but the money's already gone. So now you're trying to recuperate,
Claw
the
it
money,
back.
claw back the money, and then we're not in an attorney firm or subrogation firm, so we use a vendor. So by the time you go through this, goes through the car wash, the subrogation car wash, at the very end, this money's clawed back. There's several people that get their money. Plaintiff's attorney, right?
Yep.
Plan sponsor's attorney. The member gets a little bit of money, and then the employer really gets virtually no money back. So the subrogation process needs to be looked at too, where, hey, if somebody already paid that bill, and at the end of the day you find out it should have been subrogated, and the plan sponsor gets nickels on the dollar, there's another problem in our system.
Sure.
Yes.
Yeah, and just for the sake of clarity, subrogation is essentially when someone should be liable for the risk for the event of what happened, but the liability didn't get appropriately placed. And so subrogation involves a health insurance company or an employer essentially going and trying to find the actual owner of the risk that should be covering it as opposed to themselves.
It's tricky for the provider too, right? Because we're just
Yeah.
seeing these patients in, right? And they're, presenting their health plan. We're seeing them and trying to give, very detailed, accurate descriptions of how the injury occurred, right? And what are the details of that? And then, the patient then kind of gets in the middle of it a little bit too, and it can delay the care too for the patient if it gets, so that's the other problem with it as well. Is,
No doubt.
It can delay care
No
as
doubt.
well.
Or those employees that are trying to hide that it was a
I was going to
work comp
say
injury.
they
and-
Yeah.
twisted their knee over the weekend playing basketball, a couple of beers in or whatever, and they come in on Monday and all of a sudden they hurt
Yeah.
their knee.
They
Yeah.
hurt their knee at work. Yeah.
Yeah.
Those are the ones that are just, there's reasons why we have to have the process.
100%.
And there are things that will happen, but it's hard not to be suspicious sometimes.
In iOrtho, we do a lot of work comp business, and we pride ourselves behind it. But we, our providers know what to look for, and the employers we work with know, hey, we need detailed descriptions of what that injury was, so then we can give a true, correct causation report to that injury. And that only helps everybody, right? It helps the patient, right? Okay, if it was legit, it happened to work, we want to make sure they're taken care of. But if it wasn't, it's not deserving for the employer to be on the hook for that.
Yeah.
This is all being driven by healthcare has gotten so ridiculously expensive,
Yes.
and not one person can afford it all.
Correct.
Right. So so all these things, subrogation, coordination of benefits, denying claims, some of the insurance companies using pre-existing as you've already had that procedure, so we're not gonna pay for it again. All of it just is the fact that it's ridiculously expensive.
Yeah.
And, it wasn't that long ago, I think, the average per employee per year cost, commercial plan, was right around $5,000. And now today, latest stats I saw from either it was Mercer or Milliman, it's close to $18,000 PEPY.
And it was 15 in 2020.
Yeah, it
So-
just continues
It
to
just
just,
gets
where's the end,
changed.
right? Where's the end for these employers? That's just, we're over 400 employees, and we got to look at it as well. It's not cheap, and it's a huge spend.
Yeah, and you just drove through a parking space I wanted to actually stop in when you talked about pre-existing conditions. So pre-existing condition limitations were something that the ACA got rid of as a condition to be insured. So prior to the ACA, if you had a pre-existing condition, say cancer, kidney condition, multiple sclerosis, I'm trying to think of things that you already had the condition, insurance companies could legally deny you coverage based on that condition. But we're still seeing a little bit of prejudice around that today, but in a different way. Do you want to explain this for the audience?
Sure. So some of the things that we've seen is, especially a person who's already had a procedure, or they've been on a different plan and now are on a new plan and have a procedure, they're going in and saying that it was pre-existing. I just saw them from one of the BUCAs 2 weeks ago that it was a spine surgery and it had been there. They need additional spine surgery and they're saying it's not medically necessary pre-existing condition. How can we continue to do that and still help our members? So it's like, who's going to fight? The member's in pain, right? They want to be treated. The provider wants to treat the patient and the insurance is saying, nope, you can't. And then how do you fight it? And who fights it? And I think that's where providers get tired of fighting, right? And the member is at a loss because they just hurt. They just want to be without pain.
Yep.
And I'm not sure who's going to be that person that fights, but somebody has to fight. And I tell people all the time, as a member, as a patient, you need to be your own advocate. And if you don't know, start asking. I think that's the biggest thing. But you also have to have providers that are willing to go to bat too. And we had a member who was 32. She was a single mom. Her husband had died in a car accident. She had 3 small kids, and she was passing out. And her heart was stopping, sudden cardiac death. And the provider tried multiple things, and he's like, she needs an inflatable defibrillator. That's what she needs. Insurance said, nope, it's not medically necessary. So he argued, he went to every level of appeal, asked to go in front of an insurance board and say, I want to talk to doctors about this member. Now, not every provider can do that. He was passionate about it. He walked in and threw down what we call a Zoll Life Vest. This is big life vest that he says, would you like to wear this? It's a defibrillator on your body. It's 20 pounds for the rest of your life because you won't let me put a small incision with a battery to shock her back to life in case she's driving a vehicle or things like that.
Kids in the car.
All those things. The 3 providers were shocked that were sitting there reviewing this case with him, surprised that it got to them. He threw that thing down and they're like, it's approved. But not every provider has the time to do that. And not every provider can do that.
And not every member is going to push it that hard.
No.
To your
Yeah.
point. I think the whole pre-existing thing, really, it's really medical necessity, and somebody's deciding if it's medically necessary or not. I think we talked about before, the spine is there's a lot of procedures that get done, and the insurance, I know this is a fact because in some cases, our employers will utilize a certain network, requires that we have to use their pre-authorization, pre-certification process, their clinical team. And in a particular one, this person had a spinal fusion had been done. But the fact that it had been done before, they said, if you have another one, we know it's not going to work. So we are going to deny it, say it's not medically necessary. Now that member in particular raised it to their, human resources, which eventually got to us. And then all we had to do was we did our own, I'll call it a peer-to-peer review, but we had our clinical team review it. And this was a different part of the spine. right? As you fuse your spine, the spine around it eventually has problems. You have to have you have additional procedures. It's just kind of the natural course of care that you need. But it took a month to get through that process. And eventually, because technically the plan and the plan document, the summary plan document, states that this particular company has to do the pre-cert and pre-authorization. So we had to go through a very aggressive process. There should have been an hour-long conversation done, had the procedure. Yeah. Finally got done, but we had a very disappointed member. And we, as the plan administrator, we were blamed for that process.
Sure.
Even though we helped get it finalized. But I think a lot of it is around this medical necessity. And a lot of these services are coming out of the large insurance companies. And they're not necessarily protecting their self-funded clients, they're protecting their fully insured business.
Absolutely.
Where most of their margin comes from.
Yes.
So they do something different over here, but do something not as aggressive over here because somebody else is funding the claim.
It's ASN.
So it's all around this medical necessity thing, and people are hiding behind it.
Well, and I think medical necessity is really the bane of most providers because it's very frustrating. Medical necessity, CMS created rules. They were created guidelines that said, if you're going to do X procedure, you have to do these conservative measures first. And all providers know about that. Where it gets more complicated is that we have to get a pre-certification, but every health insurance big buka out there has said, well, I'm going to make it slightly different, and I'm going to make my rules slightly different, and I'm going to make you have 7 PT visits. I'm going to make you have 5 months instead of 4 months of non-steroidals and things like that.
Intentional obfuscation.
Right. But then how does the provider navigate that, right? And then they're frustrated because they've done all this stuff and they still say no. And then they have to do your favorite thing.
Yeah, the peer-to-peer,
Yes.
right? And guys, that's the challenging part, right? Our group is fellowship-trained orthopedic surgeons, right? They're the true experts and specialists in what they do. And, it's difficult too because I've got a whole prior authorization team, that are working through those. And exactly right, that's a challenging role to know every payer specific for certain procedures when they get denied. Right?
Yes.
How many PT visits? Okay, we have to have 80% relief on that medial branch block before we do a cervical epidural, right? Or cervical radiofrequency ablation, right? And so it's tricky. And when we get to peer-to-peers, and this is what's a little unfortunate, you get to these peer-to-peer level reviews. Problem one, they give you a time slot, usually 10 minutes at middle of the day. And then you have to have 3 hours to respond.
Yep.
Problem. And these are practicing orthopedic surgeons who are in clinic in the OR and don't have time for some of these things. And they're not very flexible.
Their time is expensive. Right?
And they're treating patients. And then once they get that peer-to-peer physician on, and I've been on these calls, and so I can personally attest to this, that provider asks the peer-to-peer physician if they've ever even practiced orthopedics, and there is zero history of that. Yep. Zero history of them ever doing the procedure they're denying. Yep. So that's what's just unfortunate, right?
They have a checklist.
Yeah, they have a checklist. The patients don't necessarily understand it.
Wow.
And it's a checks and balance system that I think is a little broken sometimes because we're just trying to treat the patient and it's just delaying the care.
Yep.
And, if we could, somehow get away from some of those and truly trust the experts at what we're doing, that's what we want to do.
I think the challenge that you have is that there's varying quality of everything and varying quality of providers, right? You show me one surgeon, you've shown me one surgeon, and then show another surgeon way over here who may be not as ethical as this one over here that does a really great job, because you've got enough of these people over here that are not ethical and they're just jamming through the system. A lot of it's fraud, right? So everything has to slow down. So in many cases, when you're trying to get great quality care from a great quality provider, the processes are built to stop the small percentage, but they drive a lot of the fraud in the system. So a lot of this, everything we're talking about today is that we're dealing with a lot of the inefficiencies in our healthcare system. And unfortunately, great providers oftentimes get caught up in the backwash on that.
Yeah, it's a balance, which I get,
Yeah.
but at the same time, exactly, the providers that feel like they're the experts and have proven track records and outcomes, it's hard because it's just more, unfortunately, overhead and time on the practice.
And no extra money for you.
And exactly, no extra reimbursement. There's no extra reimbursement for the prior team getting records, doing X, Y, and Z, physician blocking 30 minutes to do a peer-to-peer. there's no extra reimbursement for that, right? Just another hoop we have to jump through.
I want us to pivot a little bit. We were just talking about reimbursement levels for different visits and peer-to-peer reviews not being appropriately reimbursed in your experience. We got to talking a few days ago about second opinions, and I definitely wanted to visit the topic because we had a really raucous conversation around it that I thought was really good. Do you want to lead with your conversation? You made some really great points about second opinions, and then
I mean, second opinions were huge 20, 30 years ago, right? That was a big part of the health insurance and health management system. And then over time, I think part of it was either the process was just clunky and inefficient, or it even comes down to pre-cert. Like, oh, if 98% of everything's pre-cert, why do we even have a pre-cert process? But we still do. But second opinions went away. And I think part of it was everybody was trying to one-up themselves from a health plan. Well, you don't have to do a second opinion. If you want it, you get it. But I think we're now to a point where all the great technology and the advancements we've done from a healthcare delivery system and the procedures that are out there and the technology, drugs, all those types of things. Now you're finding out that based on where we're at today, I think ultimately second opinions, I think, are going to come back. Partly because there is so many new treatments and procedures and just technology in which to deal with things that we couldn't deal with 20, 30 years ago. It's been unbelievable, the advances we've made. Fair?
For sure.
So I think now you got second opinion. So it goes back to quality of the provider. So some provider they've been the best provider for the last 35, 40 years, but there might be new technology that they've not been trained on.
And I think the second opinions from a provider perspective is a little tricky because we want to treat those patients and take care of them. It also is a little, with not having the connectivity between health systems and their records, it's time, energy, effort of pulling those prior records, finding that op note if they even have it, and then getting imaging, from different providers as well that they've seen. And imaging, there's some solutions out there that kind of communicate bidirectionally, but there's not many. And so by the time you've gathered all that information, the provider needs presented that information and they need to approve it. It's just tricky because, our providers want to treat these patients, but it takes a ton of work to get there. And so with that ton of work comes no additional payment. And so it's a little like, we want to help these people, but also I think there's a piece to this that, we believe we should be compensated at least something for that additional work.
Plans used to need to be, I think they have to be updated. The summary plan documents need to be updated. So that quite frankly, if a second opinion is done, it should be covered by the plan and then pay the provider. Nobody works for free, right? We all, our time is valuable. Our expertise is valuable. So I think it may be as simple as a fix as all plan designs start covering second opinions again. Some do, not all do, right? But maybe that's the right thing to do, because at the end of the day, it's what's in the best interest of the member.
I want to talk a little bit before we wrap up here about down coding and underpayment. Do you want to give us, Carrie,
Sure, I'll give you a great one.
Yeah,
and a reason to have analytics. So we had rural practices in Iowa, and they were billing level 3 and level 4 office visits, but they were much higher on level 4 office visits compared to other people and in the city. And a certain BUCA.
Will you explain, the levels?
So we have established patient visits that are leveled from 1 to 5, and it's called level 5 or 99215, or level 4, 99214. And then there's new patient visits, and they're start with 99201 to 99203, which 201 is gone, and pretty much 99211 is gone as well. And there was also a bunch of new rules around how to code them a few years ago, which created some more drama for the healthcare industry.
Yeah, and those are CPT codes that you'll see under EOB when you've been seen by a provider that you can see, okay, 90203 correlates to this charge.
Yep.
CPT code being?
Just
it's the number that's associated with the procedure by the AMA, and it's the
American Medical Association.
Yes.
Okay.
Yep. So there's CPT codes for everything, right? Office visits, surgical codes, X-ray codes, MRI codes, injections,
Okay.
CPT codes, like, it's the Bible for how we bill medical.
Got it.
Medical claims.
Yep. Got it. Okay. Thank you.
So what was happening is that we couldn't figure out, and our revenue started to go down in our practices, and we couldn't figure out why. And so we started looking, and a certain BUCA was saying, well, there's too many level 4s. We're just going to pay them at level 3 because we can't understand why you're really spending all that time with it. Well, if anybody knows anything about farmers in America, they do not go to the doctor except if they're really sick.
Like half
And
dead.
when you get them in there, you do everything you can and you have a very comprehensive visit because you're going to take advantage of that moment in time that you have with that person. You're going to run your labs. You're going to do everything that they need on those visits. So they're penalizing because we're billing better, but we're billing better because we're trying to treat that member because that patient is very sick. That member is there, but he waited too long because he's busy. You're a farmer. You don't have time. And in rural America, that's what happens. They come when they're really, really sick or it's really painful. They've done something bad. But if you didn't have an analytic system or a big team, and I feel bad for smaller providers because they don't have the manpower and the analytical tools to go look at, well, it's not really a denial. They just aren't paying me what my contracted rate is.
Right.
And how do you fix that? And you guys talk about, you don't do that to us. I know that. You're really good at that stuff with us, helping us out. But some bukas, they just do it. Because they want to save money because they think it's overbilling. But if you didn't have a team of people or a team of experts to look for that data,
Or software to even identify it.
how do you
That's
get
the
it?
next thing. How do you know, right? And we've implemented some software to hope, to ensure that what we have signed in our contract, we're correctly getting paid on those allowed amounts. But I have one of my hand surgeons that goes to, I have a couple of them that go to rural hospitals in Iowa. I grew up in small town Iowa. I want to support small town Iowa. And you're exactly right. A couple of those hospital systems have told our providers, hey, this isn't Des Moines, this isn't the big cities, this isn't the hustle and bustle. We'd like your visits instead of being 10 minutes to be 15, 20 because our patients want to make sure we're understanding and we're thorough. That's not a bad thing. It's a better patient experience is what that is.
I feel like we're just like we were talking about earlier. We're nibbling at the edges on all this stuff
Yep.
and trying to control cost. When the bigger problem isn't necessarily at the physician level or even at your level, right, where ortho procedures are being done. Oftentimes, it's being done at the facility level. And so, if Medicare is $1, and if most of the large national healthcare, integrated healthcare systems, large hospital systems, are charging $12 to $14, that's their bill charges, and you're getting a 50% discount, you're still paying 500% of Medicare. And other people, no, our stuff, then the networks come back and say, no, you're paying only 250% of Medicare. You're still paying 2.5 times. And that number is still underrepresented. But if even the AMA says that 90% of all hospital bills are basically inaccurate, and it's never in the favor of the member or the employer, and then so if you start getting into that, how much money and waste do we have there? If you just said, listen, if we all get on the same common, if everybody was fair about their pricing and billing, and you could probably wring out 30 to 40% right there. I see it on our own health plans where we use different programs, where we use Medicare as your basis for pricing. Just doing that simple thing, you still got to go to the same hospital you want to, most of the time, not always, but you're saving 35 to 40%. So instead of paying $12,000 to $15,000 per employee per year, now you're at $8,000. And so you're not trying to nibble around the edges and drive the members crazy with all these little, we're just contorting ourselves to save a penny here, a penny here. We got to start at the top of the house and work our way down. Then I think it makes it better so that you can spend more time with the member. You can pay for second opinions, do the stuff that matters to the member. But I think the industry has gotten it's so complicated. We've been forced to nibble at the edges, and we've got these big entities that are driving a lot of what we do. And maybe it needs to be more of a groundswell where, ultimately the employers, brokers and consultants need to understand what's really happening and get down with the system and start looking for ways to actually deliver a better health plan, which quite frankly allows you to take care of the providers that are taking care of you in the first place. So I just think there's a lot that needs to be done there, but we need to start focusing on the big stuff up here because right now we're pulling these little tiny levers down here and we're not pulling the big levers on top. So.
And I think that's where, we're trying, everyone's trying to control those costs. And how do we get there better? And you're right, bigger picture, how do we get there?
Yeah.
And denials, looking at how things can change and what's the next thing.
It's the same thing with virtual direct primary care. You can get on a call within minutes.
Yeah.
And they'll actually spend 15, 20 minutes with you.
Yes.
They will, but I think there's still some technology
I
that
agree.
needs to be around there. I mean, you got guys that are like, well, I can't hear their lungs. I can't see in their ears or their throat. How can you do that? Well, you know that there's a little tool you can buy at Best Buy. Mm-hmm. It's $199. Someday it's going to be cheaper.
Right.
That you can hook up and they can actually see inside of your ears and your throat, and you can hold it to your chest and they can hear your lungs. We need things like that can be in the hands of the members so that you can do more of those types of things.
My direct primary care physician, I was sharing with Carrie earlier, she did 1 year at Indiana University Health and left, and now is a direct primary care physician. But when I started seeing her, she gave me a blood pressure cuff and an oximeter for the house. And so when I, if I'm calling her and I'm like, hey, here's what's what, she's like, well, tell me about your numbers, and and if I need to go downtown to see her, I can. But I do think that there is going to be a level of that we have to acclimate toward.
Yep. We were trying to do that with cardiac patients. We were trying to send cardiac patients home with basically a monitor they could put on their chest. It would have a blood pressure cuff. They would have a scale because we were worried about congestive heart failure. And then they would have
Retaining water, yeah.
Yep, all of those things. And it was a $900 kit that could be there. And it even had a wireless setup so that it could transmit the data. They didn't have to do anything, just plug it into the wall.
Wow.
And we could not get health insurance to cover that thing. And it's like, but it's going to save you so many office visits. Because when you have a patient in congestive heart failure, any increase in their water that they're holding will have an impact on that heart.
Right.
And it's like, but there's so many things we can do preventatively now that we couldn't do before. Right. And there are things that are deemed investigational or experimental that they won't let us do because we know it's the great thing to do. It's the right thing to do, but they just won't pay for it.
Yeah, we have one of those right now. PRP, platelet-rich plasma, is a huge one in the orthopedic space that we're offering as a cash offering to patients, and we are extremely reasonable, right? Those kits come with an associated cost, and we don't have any crazy markup. And our providers are doing these on a lot of tendinitis, tennis elbow, rotator cuff tears when we go in arthroscopy, and we fix that, supraspinatus rotator cuff tendon. Our guys are injecting that PRP to help stimulate healing because you have poor vascularization of your rotator cuff. And so we've, in the knee as well, when someone tears an ACL, we're also injecting it, and it's not FDA approved. But if you look at the studies across the land of PRP, it's incredible. In comparison to cortisone, which has been kind of the common theme for years, to inject cortisone, there's studies that show that cortisone repetitively can reduce, cartilage in the knee. And so we're trying to pivot. It's also difficult with patients when it's not approved. I think TriWest may cover it partially, but that's it. And so that's a challenge as well. So
Yep.
I was just going to say, we won't go down this rabbit hole, but stem cell therapy, again, not FDA approved necessarily in the United States, but you can go right across the board. You got some of the best stem cell clinics in the world that you might have a partial tear in your shoulder, which I don't know what that would even cost right now.
yeah,
But you can go down there and just do one treatment or 2 treatments in 3 days on that partial tear. And I think the 90% success rate where the stem cell actually helped repair it and the tear was gone. And that was only a couple $1,000, $3,000. So my point is, there's technology, but culture eats strategy. We want technology.
Yeah.
It's technology. Our government, our current healthcare system is the culture will eat that because, quite frankly, we're disrupting their, the flow of funds and where they're going.
Cardiac space is the same way with calcium channel scoring. It's a CT of your heart that it looks for potential calcium, and they get a score based on that, and it finds these patients that are higher risk for having a heart attack.
Right.
Insurance won't cover it. So the providers have started creating $99 tests. You come in, it's a 5-minute procedure, you lay on there, and you would be amazed at how many people they're finding who are not symptomatic today. They're preventing heart attacks.
Wow.
And how much money that saves, a $99 test. Why can't we add that to diagnostics? Why can't there be more diagnostic tests? Maybe even a scan of your AAA and looking up here in your carotids, making sure that you don't have blockages. those diagnostics could prevent open heart surgeries, transplants, cardiac arrest. I mean, there's so many things.
The cynic in me wants to say they won't.
We know
you live in
why.
a sick care system. Yeah,
We won't.
those are big claims. Well, Alex, Colton, Carrie, thank you for being with us today. I have a feeling we could talk about this for hours, but typically our listeners are in the car on their way to work, so they've probably driven to work over the course of 3 days by now. So we're going to go ahead and wrap it up. Thanks so much for traveling and for
Thank
being
you.
with us.
Yeah,
Great.
thanks, guys. It's fun.
Appreciate it. Super
Yeah,
fun.
Thank you.
If you haven't already, make sure that you like and subscribe to this podcast. Thanks for being here. Hope you learned something new. We'll see you next time.